Hi everyone, thank you so much for joining SoulADC today. I'm Dr. Chidamra, founder and mentor at SoulADC. Now, people who have joined me here for the first time, let me give a brief about myself. So, I've been living in Australia for around 4 years now, and people call me Chi here in Australia. I've been working in dental field for the 4 year period since I came here, and I have worked in insurance in as a practice manager as well as at back end and front end as well. So I understand how the dentistry looks like in Australia, and I gave my ADC part 1 part 2 and I cleared my ADC part 1 in just one go, so I get how the dentistry is, and I really want to help you out in clearing your ADC part 1 exam. So this is how our course content is. Now, in the previous session I realized that I have not given you a brief structure how it looks like. So if you see here, we have categorized our course into different modules from 1 to 8. 8 is where we discuss all the past papers, your ADC question banks, and we revise everything. However, from module 1 to 7, we are going subject wise. We are clearing every concept from this. So, module 1 will be your periodontology. We discuss different concepts here. Module 2 is your periodontics and your orthodontics. Module 3 is your prosthodontics. Here you complete all your toughest parts quickly. Then module 4 is your oral medicine and radiology. Module 5 is your oral surgery. Module 6 is your operative and endo part. Then module 7 is whatever is left behind, your health promotion, your code of conduct, your special category patients, all these we will be doing in your module 7. Now, if you can see, we complete our therapeutic guidelines by your module 5, and by module 6 we start revising your therapeutic guidelines. So I have pre-recorded all your therapeutic guidelines and all your content subject wise. However, we will be doing ODEL cases slowly as well, so that you understand how to solve the questions and do like that. My concept is to go it in a way that first you understand your concepts and then we discuss past papers. Now, in the past papers, what you get is all the questions with proper explanation why this answer has been selected and why the other has not been selected. And with that, I also provide you all the references. So all the modules will have their reading material, but you will also have all the answers and everything regarding your past papers. Okay, so this is how my whole course looks like. And apart from that, I also provide one-on-one mentorship. So if you have any doubt, you can obviously anytime contact me so that I can help you out very easily. We can discuss the topics if you have any doubt, and based on your pace we go ahead and do all the things. Okay, so that's what I offer you. And just want to let you know that all the content that I've prepared, it is all from your textbooks, from all the content that ADC has asked you to go through. And I've gone through all the new research papers and everything that has come up to date. So I am up to date with everything. And that's our website on the top. Now let's understand your temporomandibular disorders. I am talking about your muscles, your joint, your articular disc, everything in that spot. Okay. So what are we looking at? We are looking at our head, that is your cranial bone, your condyle, that is your mandible. Then we have your articular disc. One second. Yeah. So then we have your articular disc here. And this articular disc divides the joint into two parts, that is your superior synovial cavity and your inferior synovial cavity. So because it's a synovial cavity, it has synovial fluid, we call it as a synovial joint. And not only that, we also call it as your hinge joint, your gingivo-arthrodial joint. And here at the back, so this is your disc, and behind that part, this part will be your retrodiscal tissue. Now this articular disc does not have nerve supplies, So it is like a cap on your condyle, and it moves along with that. So if it is moving along with that and it does not have nerve supply, it will not cause pain if it is in okay condition. However, if any problem arises, we have pain. Why? Because your retrodiscal tissue has nerve supplies in it. Okay, so that's why whenever an issue happens, and if your disc goes ahead, we might have pain, we might have some limited mouth opening as well. We'll discuss all of those things slowly so that you are able to get it. So in this picture, I can see there is your lateral pterygoid muscle, which is one of your muscle for your mastication. Now there are two parts of it. One is your superior head, and the lower one, this one is your inferior head. Okay, and this joint, this location, this where the joint forms, is your mandibular fossa, and this is your articular eminence. The same thing here. This is your temporal bone, mandible, and that's your joint. Okay, so if I talk about your predisposing factors, because a person can have temporomandibular joint issues, and there can be problems. There could be something which could cause these issues, and these are those. This is purely from your therapeutic guidelines. I have not added anything from myself apart from the descriptions here. So predisposing factor, what are the factors that causes your temporomandibular joint or temporomandibular disorders? Are first is your trauma. Now in trauma, we are talking about direct and indirect trauma. What is direct trauma? When I talk about direct trauma, if you see here, getting a hit directly on your joint, that is your direct trauma. Now what is indirect trauma? Anything which indirectly affects this area. So how could that happen is, if you were in a accident, if you were in a car accident, what get hurts? Your head and neck get hurts, and that will transmit the force towards your joint, and that is called your acceleration and deceleration injury, or a whiplash injury. So this is your whiplash injury, and these are both the factors, predisposing factors in causing trauma. Now the other ones that we have is your systemic diseases. Now what could be the systemic diseases? Anything which is arising from inside your body is giving issues, like your rheumatoid arthritis. Now what is rheumatoid arthritis? Rheumatoid arthritis is a condition where basically your there is inflammation of the joint. There could be pain arising in the joint area. That's your arthritis, and rheumatoid is an autoimmune condition, right? Now when I talk about juvenile idiopathic arthritis, juvenile basically in children, anything arising in children. Idiopathic, we don't know what is the reason why it is arising. Psoriatic arthritis is also another condition which is where the patient's immunity is playing up and causing this problem. The patient will also have psoriasis on the skin as well. So these are all the conditions, because arthritis is basically inflammation happening in your joint area, and that causes some of your temporomandibular disorders, or problems can arise because of that. Systemic lupus erythematosus, again your system is happening, and that also causes your temporomandibular issues. Osteoarthritis is a condition where your bones are cramped up. There is less space, and because of which there is less gap in between, and that rubs and causes problem. Malignancies, any malignant condition, if it is growing there, it can also cause this problem. Now when I talk about your parafunctional habits, what I'm talking about, clenching, grinding, what happens there is your muscles are moving again and again. Could be parafunctional habit, or generally if you are clenching because of any stress or any other reasons. These are all the reasons why you can grind or clench. Now what happens is, your clenching is like this and your grinding is like this. Okay, so this photo is actually grinding. Now the next one is your psychosocial factors. Now what happens in psychosocial factors? Your stress, anxiety, depression, any previous trauma or any psychosocial support is not there for the patient. They, when they are in stress, they might do bruxism during the day or at night, and that causes, so that comes under parafunctional habits. So these conditions can lead to this, and this can lead to your temporomandibular disorders. Now, another condition is your chronic condition where the patient has a lot of pain in the body. That's because of the muscles. So, fibers of the muscles are causing this problem. That is your fibromyalgia. So, these are all the predisposing factors that can lead to your temporomandibular disorders. Now, your TG also says that habits such as lip or cheek biting fingernails, chewing gum, smoking can perpetuate the existing TMD problem. Anyone already having this problem, it can aggravate it. It can further cause problem. And malocclusion is not the risk factor for TMD because your TMD can cause this problem rather than your malocclusion causing TMD. Now, I just want to check if you guys are able to understand what I've discussed till yet. Thumbs up or anything?
Yes, ma'am.
Perfect. Because I can't see anyone, so that's why I might be asking in between. Okay, let's go ahead then. So, this is the predisposing factors. Now, let's understand the symptoms what a person can have. Now, if I'm talking about symptoms and signs, what is symptoms? Symptoms is what patient is observing, and signs is what we are observing. So, what could be the symptoms? There could be some common and there could be some uncommon condition. This is all from your therapeutic guidelines, your new TG. So, what are the common symptoms that a person can have? Because your TMJ, your muscles are getting involved and the associated structures, that's why you can have jaw pain, pain from the mandible with mandible function, including difficulty opening of the jaw wide, or even chewing can cause problem. Pain in and around the ears can be seen. Masticatory muscles might have pain. Headaches. So, how do you know if a person is having headache from the TMD? Is by asking history. And any person who had a headache for about 30 days, it's a possibility that it could be a chronic condition and that could be from your TMD. Then your neck pain, your joint sounds like clicking, popping, crepitus, all of these, your symptoms that we observe is mostly seen. However, uncommon could be like patient can't hear. So there is reduced hearing or tinnitus. Tinnitus is like a sound which you hear sometimes. A feeling of changes in the occlusion, where whenever the site has been affected, it is a possibility that there could be deviation in the bite, there could be deviation in the jaw a little bit left or right, something like that. We'll discuss on those as well. Then it could be toothache, that there can be tooth sensitivity, mobility, altered sensation in the face can also happen. Now, when I'm talking about signs, what could be the signs of this problem? There could be tenderness. So uh, when I am looking here, what can go wrong is I can have tenderness in the spot. Okay, there could be masticatory muscle involvement, and that causes problem. There could be sounds that I can hear, that is clicking, clunking, crepitus during repetitive opening and closing of the mouth, and your movement of the jaw when I ask the patient to move left or right. Deviation or limitation in the opening of the mouth, that is trismus, can also be seen. Now, just to understand the concept properly, so I have included a video so that you can understand, and we are going to discuss along with that as well. So just give me a second. So what exactly are we seeing is, this is basically when we look inside, that's your articulating disc, that's your TMJ disc, your condyle, and that's your fossa area, and that's your articular eminence. Now, when we remove that part and we see this is basically the disc being moved by your lateral pterygoid muscle. So, your lateral pterygoid muscle is really important for causing problems as well. So, that was what we saw in the first video. Now, the second video tells us about the movement of your jaw. Why is it not moving? Okay. So that's how the movement happens. Now, this was basically, when we see here, this is actually a rotation movement of your jaw. Now, this green arrow at the bottom, that was actually your another type of movement, that is your translation movement. Okay. So these are the two movements that we see about your jaw, your mandibular jaw, when we look at. So whenever a person is just opening around 20 millimeter, I'll say it's a rotational movement. And once a person moves more than 40 millimeter, we'll say there is a translation movement happening of the jaw. So it is moving, you are opening your mouth, that's your translation movement if you're opening it wide. Now, when I talk about your temporomandibular disorders, it's been categorized into four parameters. So, first is your joint disorder. Now, whenever we are talking about the joint, we are saying it's an intra-articular disorder. When we talk about muscles, your muscles of mastication, we talk about extra-articular disorders. Then we have headaches and associated structures causing problem, like your coronoid hyperplasia. Okay, so coronoid hyperplasia will be your coronoid process, it is getting enlarged, and that is causing problem. Okay, so coming to your joint disorders first, let's go one by one. So now I have shown you how the basic structure looks like. So I'm sure you will be able to understand when I start things one by one. So when I talk about the first thing, that is your joint pain. So in joint pain, we have arthralgia and arthritis. Now, algia, whenever we'll say, we are talking about pain, and arthralgia will be about your joint pain. If it is myalgia, I am talking about muscular pain. Okay, so arthralgia, pain coming directly from your TMJ itself. It is usually felt with jaw movement or chewing. And how are you able to get it that it is arthralgia and not something else? Is by palpating in that area. You will palpate and see how the patient is responding to it. So patient will have problem on opening, lateral movement, or your protrusive movement. What is protrusive movement? Moving the jaw forward. So that's your protrusive. Lateral is side by side. Okay, and arthritis means inflammation of the joint, and that causes pain as well. Any doubts so far? If you guys are able to understand, please send a thumbs up. Okay, great. So let's go ahead. So the next one is disc disorders. Now, what happens with disc disorders? Now, if you see, this pink part is your disc. That's your retrodiscal tissue. So as the name says, retro means at the back, and discal because it is behind your back. That's why. Okay. So what happens in disc disorders? Before we go ahead, let's look at this video.
The most common disorder of the TMJ is disc displacement, and in most of the cases, the disc is dislocated anteriorly. As the disc moves forward, the retrodiscal tissue is pulled in between the two bones. This can be very painful as this tissue is fully vascular and innervated, unlike the disc. The forward dislocated disc forms an obstacle for the condyle movement when the mouth is opening. In order to fully open the jaw, the condyle has to jump over the back end of the disc and onto its center. This produces a clicking or popping sound. Upon closing, the condyle slides back out of the disc, hence another click or pop.
So what do we get here is basically when I'm talking about disc disorders, there could be displacement of the disc. So where the disc is going in this situation, it is going forward, it is going ahead of your condyle. Generally, it should be like a cap, like a hoodie on the top of your condyle. And if it goes ahead of it, what can go is, we call it as disc displacement. Now there are two things in this. One is disc displacement with reduction and the other is disc displacement without reduction. Now with the word reduction, we mean that it is going to go back. Problem is still can be manageable. So disc displacement with reduction will be where the condyle moves back. So this condyle will go back from here to here, from this position to this position, and there will be a click or a pop sound that can be heard. However, if a situation happens that this disc is stuck forward, it stays there and it does not allow, so it will be here somewhat, okay, and what will it do is it will not allow your condyle to move forward. And what happens with that is, just imagine your condyle is sitting back, your disc is stopping the way, it is like a door in front of it, not allowing it to go ahead. Then what will happen is your jaw will lock in that position, it will be closed. So if it is exactly at the back position, it has not been able to come forward, we say it as closed lock. So without reduction, whenever we talk about, we are talking about closed lock. So the disc is stuck forward, so limited range of motion happens. There will be trismus, patient will not be able to open the mouth too much. Little bit possible, but not possible without reduction, in the without reduction case. So there will be clicking in the joint, intermittent locking and recurrent dislocation can happen. Now one thing for us to know is when we talk about disc displacement with reduction, so your condyle is moving, it goes back, and this is your retrodiscal tissue, and there are nerve supplies in this area. So this is going to cause pain in the patient. Now other thing that we need to know is this tissue, what happens is when this is happening repeatedly with reduction sort of issue is happening repeatedly, what goes wrong is this retrodiscal tissue will become thick. So fibrosis of this will happen, and slowly your body recovers and it behaves like a it starts behaving like a disc, this disc. So this will be your TMJ disc, behave like that. I'm talking about that, okay? Now the third thing that we see here is adhesion, ankylosis or hypomobility. Now when the word comes hypo, it means reduce in the mobility, and ankylosis, as we use it in our teeth as well, ankylosis means it has blocked, it has stopped somewhere, it has fused with each other. So what happens with that is, if fusion happens, there will be stiffness, there will be no opening of the mouth or reduced opening of the mouth. So this stiffness could be either fibrous, that is the fibers that has got stiff in that location, or osseous. Osseous means your bone getting stiff. So it is combining and it is becoming stiff, so that patient is not able to open mouth. Now the next one is your disc dislocation. Now what happens with dislocation when I'm talking about at the back? When your disc goes back, and so your disc is at the back and your condyle is ahead of it. In this situation, just imagine your jaw has opened, your disc has gone back, and now you're locked. So you have locked your mouth open. So that's why it's called open lock. So condyle is positioned anterior to the eminence without the ability of reducing on its own. This is termed as dislocation. So patient might not be able to close by themselves. We might have to help them, or they have to do additional treatment to get it back. When we view it laterally during opening, the condyle level will be 15 mm anterior. So this is the reference point. The condyle goes around 15 mm ahead anterior, and the disc travels 7 mm from this point. So this is your open lock condition. Now, when I'm talking about your jaw locks, now jaw locks we have discussed two types. So lock are of two types. One is your closed lock and the other one is your open lock. Now this one was your open lock, and this previous one that we discussed here, that was your closed lock. Okay. Now if a lock is happening because of your joint, because of your condyle and your disc, it is basically your intra-articular jaw lock, and what happens here is patient is not able to move the jaw in any direction. However, when we are talking about muscle stiffness and that causing locking, there will be some movement happening, so only vertical restriction will be there. Apart from that, other movements of the patient will be seen. So this is how you compare between your intra-articular and your extra-articular, that is your muscles causing locking of the jaw. Now let's discuss about degenerative joint diseases. So we have discussed about these conditions. We have discussed about...
Hello,
Yes,
Chidambara, can you repeat that one? The
Which one?
previous, this thing.
which one?
Just before this, what you said.
The locking, two types of locking.
Yeah, closed.
Okay. So your locking could be, one is by your bones, your jaws. That was your intra-articular. Let me explain from
Yeah.
here. 1 second.
Yeah.
So we discussed intra-articular is joint disorder, and extra-articular is your masticatory muscle associated disorder. So when when I talk about your lock, it could be either because of your joint, that is your extra-articular, or it could be intra-articular. Oh, I'm sorry, extra-articular means your muscles, intra-articular means your bones, your joint. Okay, and when I talk about your intra-articular lock, they are of two types. One is your closed and your open. Now when I'm talking about your intra-articular one, because it's your joint has it's been held in a position, that's why it is not able to move in all the directions. It can't move on your lateral side, it can't open, or it cannot close when we are talking about your open or your closed type of joint. So it is stiff in one place. However, when I'm talking about your extra-articular, I'm talking about your muscles. So when your muscles get stiff, and because of which locking happens, your vertical movement will be restricted. So opening and closing will be locked. However, you can move left and right. So by that you can differentiate between the two types of locks. Is it because of the muscles or because of the joint? I hope it's clear now. Okay. Now let's go on to degenerative joint diseases. Now, as I was talking about, we have covered this part, we have covered this part. Your hypomobility will be reduced in the mobility of your joint. That is, your ankylosis is a part of it. We discussed about it. Your hypermobility will be too much movement causing problem. We'll discuss things slowly. So these we have discussed. Now when we talk about your degenerative type of joint diseases, we are talking about your osteoarthritis, your systemic arthritis, your idiopathic condylar resorption, your osteonecrosis, your neoplasm. Let me explain everything one by one. So the first one is your osteoarthritis. As I was telling you before, what happens is everything in the joint area is crammed up. There is less space. So if you see this one, this is normal condition. However, in osteoarthritis, if you see, the joint space has been reduced. So that's what happens. So it's a chronic degenerative joint disease of the joint, where the cartilage and the joint surface breaks down over time. In more advanced cases, it can lead to joint shape changes and bite problem. Your joint might even look, your condyle might look even flat sometimes when we see in OPG. So these all things can happen. That is a degenerative joint disease. Whenever we talk about the word chronic, chronic means long standing. Now, there are other conditions that I've mentioned here. One is your systemic arthritis. We have discussed when your system is acting on, there is inflammation happening. That is your systemic arthritis. Condylar resorption, idiopathic means we don't know why resorption of your condyle happens. That is one of the conditions. When we do not have the risk factors of it or the predisposing factors, we are not aware about it. Your osteonecrosis means, osteo means bone, necrosis means death. So what happens with osteonecrosis? Basically death, that is your nerve supply is not there in that area, and because of that your cells do not work up and they do not heal up. So if a person got radiation, what can happen with that is, if radiation got exposed there, osteoradionecrosis can happen. Okay, so this is basically your osteonecrosis. And when I talk about neoplasm, we are talking about your tumors can be there. There could be neoplasms which could be benign or malignant in nature. There are 10 types of benign tumors seen in the TMJ area. The most common is your osteochondroma. Your osteochondroma is called a true neoplasm. Now, what does true neoplasm mean? True here means it is replicating, it is multiplying, it is growing quickly, and all the signs of neoplasm are seen. So that is your true neoplasm. And it affects your condyle. I'll show you the pictures in the next slide. I'm just explaining you here. So what happens is, unilateral condylar enlargement will be seen because in chondroma there is growth happening. So if growth is there, there will be enlargement observed. Okay. Dentofacial asymmetry, because one side is getting enlarged, there will be symmetry will not be there. There will be asymmetry observed. Chin will be deviated. Unilateral change in occlusion will be seen. Unilateral condylar enlargement will be seen. Preauricular pain. Preauricular means ahead of your auricule, your ear area. Ahead of there will be pain. There could be swelling, there could which is non-tender. Bony hard swelling can be observed because osteo means bone and there is growth happening. That's why hard swelling will be there. Now, OPG will show us that the condyle neck has shortened down. There is flattening and widening of the condylar head. Your CT will show us your soft tissue involvement, and your MRI shows us your soft tissue involvement with nerves and vessels getting involved. So if we see in this patient, so generally whenever we see an OPG, just remember, because what happens is, when we see in a mirror, we see our left becoming our right. That's your transposition. So that's what happens. So your left hand is actually going towards your right side. So this is your right and this is your left. Okay. So this patient, if I divide her face, it's right and then left. So what do you see in this? Let me erase it. So basically her right side has been affected, and what has happened is there has been deviation of her mandible, and if you see, her chin is not in center. Okay, so what do we infer from here is there is deviation in the patient to the opposite side when there is osteochondroma. Okay, there is growth happening here. And in this is a different patient, not the same patient, happening on the left side. So now let's discuss about your extra-auricular. Now, extra-auricular means your muscles of mastication causing problem. The issue is happening with that. So there are 4 muscles of mastication that we are more concerned about. These are your masseter, your medial pterygoid, your temporalis, and your lateral pterygoid. Now, before we discuss anything about your extraauricular, let's look at this video. So that's your temporalis and your masseter muscle. Okay, so these were all your 4 muscles, although there are other muscles in your mastication as well, but we are discussing about only these 4 right now. So whenever I'm looking at these words, I can see a word called myalgia. Now algia is for pain, so myalgia will be muscle pain. Now there are different types of myalgia that we are talking about. Your first one is your local myalgia. Now in your myalgia, we are talking about 3 types: your local, your myofascial, and your myofascial pain with referral. There is one trigger point, but there is slight variation in all the 3 types. Your local myalgia means pain is confined to a specific muscle. So whenever you touch, there will be pain at one specific spot. So when pressure is applied to the muscle during evaluation, pain is felt only at an exact site. So here we see local myalgia only at one spot where the pain will happen. So patient often describes the sensation as sore, stiff, tight, or aching, or there could be fatigueness observed, especially after activities that strain the jaw, such as prolonged chewing, clenching, grinding. All these can cause this problem, and that's your local myalgia that we are observing. Now, myofascial pain, when we talk about, we are again talking about single muscle, and there, if you see, trigger point is here, but the pain is happening around that same, on that same muscle. It is not spreading anywhere else. So myofascial pain, the pain extends beyond the palpating fingers but remains within the borders of the muscle being palpated. When I talk about your myofascial pain with referral is it is spreading to other place as well. So if you see in this picture, it is spreading to other areas as well. So the pain pattern extends even further from the affected muscle. So when you are examining, although the trigger point is going to be one point, however, it is going to spread to further areas as well. So pressure on a tense muscle band or trigger point may reproduce symptoms in a distant location beyond the boundaries. So we are talking beyond the boundaries of the muscle. It is spreading in that area, and that's how we are able to differentiate all 3 of them. Okay. Now let's go on to one more thing, that is your myofascial pain dysfunction syndrome. Now what is the difference between myofascial pain dysfunction syndrome and these 2 is we have one trigger point. However, in your MPDS, your myofascial pain dysfunction syndrome, there are multiple trigger points. So when you touch, patient might have pain in different areas, not in single muscle, there can be in different muscles. So there is pain, muscle tenderness, there is clicking sound of TMJ, limitation of jaw movement, all these issues can happen. Now let's discuss about the other issues, that is your tendinitis. Now what is tendinitis? Tendon. So problem happening in tendon, there is inflammation of the tendon. Now what is tendon? Tendon is basically your connective tissue which is connecting your bone and your muscle. So if a problem happens, your trigger point will be where your temporal bone, if you see here, your temporalis, where it is ending, where it is connecting with your bone, there will be pain. So pain originating from tendon structures such as tendon of temporalis muscle, which is palpated intraorally at its insertion on the coronoid process of the mandible. So whenever we go from inside your mouth and we palpate, patient might have pain at that spot. Now when I talk about your myositis, I am talking about, sitis means inflammation. So this is a chronic inflammation or it's an infectious muscle involvement, and that causes your localized pain, swelling and trismus. And when I talk about your spasm, spasm is basically your muscles going into spasm, and that causes problem. So citis is inflammation and there is infection happening. However, when I talk about spasm, it's basically your muscles are getting spasm. For example, your lateral pterygoid muscle gets affected. So that going into spasm can cause problems. So it is involuntary tonic muscle contraction that results in limited opening, and in some cases acute occlusal changes can happen. So spasm of your lateral pterygoid muscle may pull the mandible towards the contralateral side, opposite side, creating a posterior open bite. So if you see this picture, let me zoom this a little bit. So if you see here, there is a little bit of gap here, and that's because of your lateral pterygoid muscle going into spasm, and because of that there is slight open bite might be seen at the back. And after treatment, here we can see after 8 weeks the condition has improved. Now with respect to the management and all, I won't be able to cover that today, but we are just discussing about the conditions. And for the management and your how to diagnose, how to identify, might be in a different lecture, maybe in a different class. So contractures, when I'm talking about contractures, what happens is your muscle getting into fibrosis, so stiffness of the muscle happening. So if anything gets stiff, if suppose you think about a sponge going stiff, what will happen with that is it will shorten. So muscle shortening due to fibrosis. Progressive loss of range of motion will be seen. There is unassisted or assisted opening. When we observe how much is the opening of the mouth will be reduced less than 40 millimeter, and that's either when you are assisting the patient or even the patient is trying to open by itself. So opening by itself or using hands and trying to open it, the opening will be reduced. So there is resistance to assisted movement. And why does this contracture happens is because the calcium uptake happens by the muscles, and when that happens, what goes on is your blood vessels start compressing, the muscle fibers starts getting stiff, and there is local muscle ischemia that happens, and that causes pain in the patient. Now when I talk about hypertrophy, hyper is something more. So hypertrophy is basically your muscle getting enlarged, and this is usually a non-painful condition associated with overuse or because of any genetic condition as well. So what happens is when you see a patient, you might see this area looks a little bit larger, or you can say broader than this area. There will be slight variation happening on both the sides. So evidence of enlargement confirmed by photographs or previous record. If the patient is coming to you for a longer time, you can compare and see how the difference look in this area. Now there is this, why does it happen, is because of your parafunctional habits. Could be because the person is in lot of stress that is causing clenching and bruxism of the patient. Then we have orofacial dyskinesia. Now what happens in this is patient is repeatedly moving muscles. It could be because of the tongue moving a lot, or it could be other muscles that might be moving and causing problem. So if you see this one, see how the patient is moving, and it is involuntary in nature. Patient cannot control it. So this condition is your orofacial dyskinesia. There is another condition called tardive dyskinesia, where more than your face, other parts are also getting involved. So please remember this one. You can take a screenshot of this slide. Here, these are the jaw movements on opening. So if there is your TMJ ankylosis, so fusion of your TMJ happens, what can go is, where will the movement of your jaw will be when you're opening it? It will be on the affected side. Just imagine if I'm not visible, one second. So if suppose the joint gets fused, and this has limited area. So this area is limited. However, this gets fused. So when you try to open your mouth, it will deviate towards the affected side. I'm trying to explain how you can think about it so that you don't have to memorize it. Is you are trying to understand that when you are opening your jaw, if this area is fused, the area in this area gets reduced. There is less space, and that's why it moves towards the affected side. Although the mouth opening is going to be highly restricted, but if there is opening happening, it will be towards the affected side. Now, if there is hypomobility, unilateral TMJ hypomobility, there is reduced movement, there is stiffness happening, deviation is, this is actually almost the same thing. It is affected on, the movement will be on the affected side. Now, disc displacement without reduction, deviation is towards the affected side in this condition as well. Condylar fracture, if a fracture happens, the deviation is also towards the affected side. Your ankylosis happens is if both of your jaws are getting closed, ankylosed. What can happen is, just imagine ankylosis happening, they are not able to open the mouth. So no deviation will be there because both the sides are getting affected. Your pterygoid myospasm, your lateral pterygoid muscle myospasm happen, spasm of the muscle happen. The deviation is also on the affected side. In your osteochondroma, we discussed it is on the opposite side that happens. Your condyle hypermobility also opposite side. Rest, we are talking, it is on the same side, the movement. Okay. Now here we are seeing there is an enlargement happening on this left side of your jaw. That's I just wanted to show you this picture. Now, one second. So headaches, let's discuss on the headaches. So presence of headaches in the temporal region, if the headache happens in this part, for the last 30 days, if the patient complains of, we are talking about the TMD headaches. And that could be because of your functions or your parafunctional habit, like normal chewing, your functional habit. Your parafunctional habit will be like your bruxism, your clenching. The clinical component consists of confirmed, localized. So basically, there is localized headache happening in this area. This area is only getting affected, especially when the patient moves or when we are able to palpate this area. So that's how we are able to differentiate this type of headache. Now, there is one whole case in Odell which talks about different types of headaches. I will recommend you go through that. You will come to know the different types of headaches, the cluster headache, your TMJ type of headache, or any other type of headaches, and that will really help you to understand this concept. Now, the last one is your coronoid hyperplasia. Now, coronoid hyperplasia I've already explained in the initial slides. So, it is a rare abnormality. What happens here is hyperplasia. There is some enlargement happening. So what happens here is your, if you see here, your coronoid processes, this one, there will be enlargement. Generally, if you see, it is not that clearly visible because it is ending like here, and here it has gone further. So that's your coronoid hyperplasia. It affects both the sides. It's a rare condition, and it is painless, but there will be restricted mouth opening. So in the patient having trismus, if you see, the mouth opening has been reduced. So that's all for today. Any doubts so far, or was it okay? If anyone has any doubt, you can send me, you can message me. I will be happy to help you out in whatever we have discussed till yet. Although this was a very dry sort of topic, but I tried to make it a little in a different way so that you can understand it. Please send me a thumbs up if you were able to understand it. great. Yes. Yes, I can repeat that definitely. This
The
slide?
most common
I'm sorry. Yeah. So, I was discussing about disc displacement with reduction and disc displacement without reduction. Now, just imagine reduction is something which is going to go back. The things can still be improved. However, when I talk about reduction, without reduction, I am saying it is getting locked in a place and it will not improve. So, let me explain you further. Let me explain you again. 1 second. Okay, so disc displacement with reduction means when you see this video, your condyle and your disc is going ahead and it is coming back. However, it is not locking in a position. It can move. Patient is able to move the mouth, can open and close the mouth easily. However, there will be a click and a pop sound that can be heard. That is your disc displacement with reduction. Now, when I talk about your disc coming at the front and stopping, acting as a door, a guard on a door, and it stops further movement of your condyle. That will be your disc displacement without reduction. And because your condyle stays here and your disc is in this position, and this is the normal position when the patient's mouth is closed, so this condition will be called as closed lock. Okay, so without reduction, yes, Rutvi, closed reduction, closed lock is your without reduction. Okay, and when I'm talking about your open lock, I am talking about your disc getting situated at the back and your condyle basically going ahead and getting locked in that spot. So it is stable in that spot. Patient might not be able to close the mouth. Okay, any other doubts? Anything you want me to repeat? Okay, so if you have any doubts, you can definitely send me through, and either we can discuss. So everything will be in my modules. I have already made things up. However, if you like, we can discuss TMJ furthermore. But I can't complete everything in one class because I don't want to make it confusing for you furthermore. So I have two courses for ADC Part 1. One is your 5-month sprint course and the other is a 10-month comprehensive course, where, as I showed you in the beginning, we have all been pre-recorded your TG lectures as well as subject-wise lectures. And this is how it looks like. So there will be videos so that you can go through it, and we go through all the Odell cases together. Yes, I have recorded it, so don't worry. I'll make it available so that you can revise again and ask me doubts. So, and all the content that I've prepared is from recent research articles and the books and all what ADC want us to go through, so that you are up to date and you don't go through all the old content. So I have added everything into my modules, and these are how I've already showed it in my previous session as well. So everything is in pre-recorded videos are like these, and you will see there are documents also that I've uploaded. So there are reading material. If you like reading them, definitely go and read those. And if you like listening, definitely my listening content also has all the notes. So if you liked how I explained today, that's how I actually make all my videos. It's exactly in the same format. There will be pictures, videos, as well as notes, so that you can learn and you can understand things at the same time. And whenever you see that there is a doubt, you feel you have a doubt, you can definitely anytime just message me, and I will be happy to book a meet one-on-one session on Google Meet, and we can always solve it out. So thank you so much for today, everyone. You can take a picture of this page so that you can follow us. If you are not on WhatsApp, in our group, you can join us. If you're not on Instagram or Facebook, please join us, because I will be posting further things, any updates, or sometimes I also make creative videos for the topic to become interesting, especially from your therapeutic guidelines. So you can join us there. Thank you so much, everyone. Hope to see you soon, possibly next Saturday.